Hi everyone. First of all, welcome to this session. I'm Dr. Erol from Indian University. I'm a research scholar in Indian University right now, and I'm trying to talk about the endoscopic approach to the jugular foramen as I could. I think it is the most complicated anatomies in the endoscopic point of view, but I'm trying to keep it simple and trying to keep it my best. So I have no disclosure about this talk. And I also have a brief introduction for myself. I was a neurosurgical resident in Gazi University, and these were my mentors in Gazi University, Dr. Emmez, Dr. Kaymaz, and Dr. Çeltikçi. My interest of skull base actually start in my residency program. And then I had a chance during my residency program to watch some of the cases of Professor Tures and perform some of endoscopic and transcranial skull base approaches in the lab. And I realized that the performing this type of complicated surgeries, we need actually cadaver lab experience. I think it is essential for learning that. And then I went to the Adıyaman Research and Training Hospital. I'm still member of this hospital actually, but during my job, I also decided to improve my skills about skull-based surgeries. And now I am in the Indian University and I am doing my researches under supervision of Dr. Almeida. I think he is one of the most talented skull-based surgeons in the United States. And he's really a good person. He's Brazilian, and he really supports us about learning and improving ourselves in skull-based surgery. 2 years ago, actually, I had a talk in also the İzmir Online Neurosurgery, and I really love this platform. And as I could, I tried to join every session. And 2 years ago, I had a chance to present my studies and works in another lab, Yeditepe University lab. And today I'm going to present my presentation from different country, different lab, and different works. And it's a really big pleasure for me. I always mention about this in my every presentations. It is my only picture with Professor Yaşargil, rest in peace. I never meet him in a person, but I always take him as my mentor. It is from also İzmir Online Neurosurgery meeting. You can see Professor Sucu in here. It was the Professor Tures epilepsy talk. And this talk, there is a little contest actually that you gave the three person who win the contest the books from Yaşargil's book, and also it is signed by Yaşargil himself, and it is most valuable book in my library still, and I still thankful for this book to you, Professor Sucu, and whole team. Now, today I'm going to talk about the endoscopic endonasal approach to the jugular foramen. Like I said, this is a complicated region. First of all, I need to mention about this guy, Dr. Çeltikçi. When I was resident, Dr. Çeltikçi started in Gazi University, and I had a chance to watch him growing as a skull-based surgeon from day zero to the most complicated skull-based surgeries. I see all the learning curve, all the surgeries, all his approach. I can have a chance to follow him steps. So also I'm thankful for him to improve my skills and let me also do something about this region. He always mentioned about the concept of the sagittal planes and the coronal planes in the skull-based surgery. The sagittal plane actually meaning of the midline of the skull base and endoscopic endonasal approach to midline skull base. The midline, which location we mentioned about. The anterior skull base actually from the frontal sinus to the level of the posterior ethmoidal artery, and the middle skull base actually is the sphenoid sinus cavity. We can reach from the sphenoid sinus cavity, and the posterior skull base is starting from the dorsum sella to the coniovertebral junction. But all the structures that I mentioned is placed in the midline. So most of the neurosurgeons are actually familiar, these midline skull-based surgeons. What is the steps? It is we are mostly familiar. First, we go from the right or left nostril or bilateral nostril. It is right nostril. We can find the inferior turbinate and the middle turbinate. And then we lateralize the middle turbinate. We find the choana and the sphenoid matrices, and upper level of the sphenoid matrices, we can find the sphenoid ostium like in here. It is the first essential steps of this. And then after the posterior septectomy, we can find both ostiums of the sphenoid sinus and remove the sphenoid rostrum, and then remove all the mucosa in sphenoid sinus, and we reach the sella and the paracellular region, upper clivus and the tuberculum cellular region. most of the neurosurgeon and as me, we are familiar with this approach because we mostly perform this approach. But the things little bit get interesting when we try to reach the coronal plates. Like we can reach to the orbita, especially the tumors located like medial of the optic nerve. It can be some schwannomas, mostly cavernomas. We can also use the nasal route to reach this region. 2 weeks ago, there was Professor Karo's speech in the İzmir Online Neurosurgery. I also attend this topic too. It was excellent speech. And he mentioned also about the pterygopalatin fossa approach and the infratemporal fossa approach. Also in the coronal planes, you can reach this region. Also, I'm going to mention about this too. And then today's topic about reaching the jugular fossa. So what is the jugular foramen? Actually, jugular foramen is two large openings in the base of the skull base. You can see in here. It is just located behind the carotid canal. And it is very important structures that going inside from this foramen, like inferior petrosal sinus, the sigmoid sinus, and the internal jugular vein junction, and the glossopharyngeus nerve, valgus nerve, and the accessory nerves. So there is some important venous structures and neural structures inside in this foramen. And you can see it is the carotid canal and it is our jugular foramen. This is just behind the carotid canal. So it's formed by the petrous part of the temporal bone you see and the occipital bone. And it is our jugular foramen in here. So we can divide the jugular foramen to 3 compartments for understanding the anatomy better way. In the posterior lateral compartment, it is the sigmoid compartment because the sigmoid sinus is running along in this sulcus and drain the jugular foramen in here. And it is the anteromedial compartment. We can call also the petrosal compartments because the inferior petrosal sinus is running along in the petroclival fissure you can see in here and go inside to the jugular foramen. And it is the neural compartment. It means the intrajugular compartment. The 3 cranial nerves, lower cranial nerves, are going inside from this jugular foramen. So which approach actually we can use for reaching to the jugular foramen region? There is not just, of course, endoscopic approach. It can be the lateral approach, it can be far lateral approach, infratemporal fossa approach, and today's topic is the endoscopic endonasal approach. The lateral approach I'm going to mention is the retrolabyrinthine approach, translabyrinthine, transcochlear, or retrosigmoid approach can be. This meticulous dissection performed by our fellow in the lab, Aysu Kabakçı, also Turkish fellows in our lab. We are working together. And in her dissection, you can see the lower cranial nerves and the sigmoid sinus and the jugular bulb going inside to the jugular foramen. But for the retrolabyrinthine or named infralabyrinthine approach, we can preserve the hearing and we can use this approach for the small or medium jugular foramen tumors like the glomus jugulare. But if we need increase our exposure for the larger tumors, like larger glomus tumors, maybe schwannomas, and if in the patient's neurological examination or the surgeon's choice, if we need to sacrifice the hearing, we can also use the translabyrinthine or transcochlear approach. And you can see the close-up picture, and the nerves is going enter also the sigmoid sinus going enter the jugular foramen. Far lateral approach, there is standard far lateral approach we can use, also the extreme lateral approach. It depends on the tumor size, how tumor spread laterally, and what is the tumor's pathology. And you can see in here, the lower cranial nerves is just going inside to the jugular foramen. Most of the time we use the retrosigmoid approach or the far lateral approach, the intradural part of the jugular foramen. And this dissection also from our former lab fellows from Gabriel from Colombia. You can see that we drill the occipital condyle for the more extensive approach, and also we can mobilize the vertebral artery so we can increase our exposure and we can reach also the jugular foramen region. Infratemporal fossa approach, actually, like I said 2 weeks ago, Professor Kara had a great speech about it, but mostly he mentioned about the endoscopic approach for the transpterygoid and the infratemporal fossa approach. But as neurosurgeons, we are also a little bit familiar for the transcranial approaches. It is for incision for infratemporal fossa type A approach. Mostly it's called a fish approach. In this approach, you need to also do the infralabyrinthine or retrolabyrinthal petrosectomy and the mastectomy, so it can expose the sigmoid sinus. And the lower part of the sigmoid sinus, we can reach the lower cranial nerves. But it depends, like I said, it depends on the tumor size, how tumors spread laterally or medially. Even this is the type A, but in type B or type C, it is more extensive surgeries. Even type C, we sometimes need the mandibular sieving or mandibulotomy for increase our exposure. But this type of type A, neurosurgeons can also perform this type of surgeries, and it is really ideal for the jugular foramen tumors. And of course, today's topic about the endoscopic endonasal approach. I have to mention about this. This endoscopic endonasal approach is particularly used for the tumors that extend from the clival or petroclival region to the jugular foramen. I mean, we use this approach rather than primary jugular foramen tumors. If there is tumors like chondrosarcomas or chordomas originating from medially and spread laterally to the jugular foramen, especially for this type of situation, endoscopic endonasal approach more suitable for the primary jugular tumors. Also, it depends on the tumor and like size, spread. You can combine all this type of approach and reach the try to best to remove the tumor like gross total way. So when we look the skull in the endoscopic endonasal view, we need to define some bone structures like occipital condyle, like hypoglossal canal, jugular foramen. So we need to use these bone structures as landmarks. I'm gonna mention more detail in my further slides. So for reaching the endoscopic endonasal route to the jugular foramen, it is not actually possible due to the position of the pterygoid plates. So what is the pterygoid plate? You can see the sphenoid bone right here. In the bottom of the sphenoid bone, there is two plates. It is the lateral pterygoid plate and it is the medial pterygoid plate. For reaching this region, especially a medial pterygoid plate is our way. So it just narrows our surgical field and it does not allow us to adequate exposure for this region. So in order to access the ventral part of the jugular foramen, we need to drill out the medial pterygoid plate. So for exposure of the jugular foramen in endonasal route, there is three steps that we need to pass. It is the transpterygoid approach, far medial transclival approach, and the extreme medial approach. I'm gonna mention step by step from these approaches. In beginning of my presentation, I mentioned about if we need to reach the cellular or paracellular region, we lateralize the middle turbinate and reach there. But if we're going to go for coronal planes, we're gonna retract the middle turbinate to medially. And so we can find it is the bulla ethmoidale, and it is the uncinate process of the ethmoid bone, and between them there is the hiatus semilunaris. So when we dissect the hiatus semilunaris, we're gonna reach the entrance, the ostium of the maxillary sinus. Some of the people or some of the specimens, I can say, there is also alternative opening of the maxillary sinus, but it is not the real opening of maxillary sinus. Most of the people, you can find this type of opening. So for reach the maxillary sinus, we need to dissect from the hiatus semilunaris and find the real ostium of the maxillary sinus. After I performed the uncinectomy, removing the uncinate process of the ethmoid bone, we can reach the maxillary sinus. You can see the real ostium of the maxillary sinus, and we see the posterior wall of the maxillary sinus, and it is the maxillary sinus. For this type of approach, you can use like 30 or 45-degree endoscopes, because sometimes the 0-degree endoscope, you cannot see all the structures that you need to see. Before going lateral of the pterygopalatine fossa, it is important to mention about the palato-vaginal artery. You can see right side in here and the left side in the left. Before going to the lateral of the pterygopalatine fossa, we need to identify and decoagulate the palato-vaginal artery, because if we can't control it or like translate it before we go this place, it can be bleed, and it is sometimes hard to stop the bleeding of the palato-vaginal artery. After insulinectomy and the medial maxillectomy is performed, it just exposes the posterior wall of the maxillary sinus. In the both photos, you can see my double probe dissector I put in this region. It's called sphenopalatine foramen. For find the sphenopalatine foramen, it is key to identify that the sphenoid process and orbital process of the palatine bone, which covers the sphenopalatine foramen and the artery. But I am also know that as neurosurgeons, we are not familiar actually with palatine bone. We as the anatomy and all the processes, everything. So I'm going to speak about the palatine bone really quickly. So in the right side, you can see it is just sphenoid bone and the palatine bone. Palatine bone has two processes. One of the processes is the orbital process. The other one is the sphenoid process. And I'm going to expand the bone. You can see it is our palatine bone and it is our sphenoid bone. Between these two processes, there is a gap. And the posterior border of this gap is the sphenoid bone, sorry. And altogether, they can form the sphenopalatine foramen in here. And sphenopalatine artery just courses from this foramen. And then after I identify these structures, I remove the orbital process of the palatine bone and increase my exposure in there. So remove of the posterior wall of the maxillary sinus. It is the posterior wall of the maxillary sinus. The first step the first layer that I'm gonna see after remove of the posterior wall, it is the periosteal layer of the maxillary sinus. It is the first layer of the maxillary sinus, and then after opening of the periosteal layer, we reach the inside of the maxillary sinus. It is the vascular layer and the neural layer. But there is none of any fat tissue because I clean all the fat tissue in here. But after opening this periosteal layer, you're gonna see a lot of fat tissue in here. But for the cadaveric dissection purposes, I removed all the fat tissue and I showed the arteries and the nerves in here. You can see the foramen rotundum and V2. V2 is going to infraorbital nerve, and also the internal maxillary artery and the branch as the sphenoorbital artery in here. I'm going to show in a better fashion. I cut the sphenopalatine artery so I can show better way the foramen rotundum, and the maxillary nerve is coming also go to infraorbital nerve, and it is the pterygopalatine ganglion. And as we know, the median nerve is going from the pterygopalatine ganglion, so we need to find the ganglion and we need to find the median nerve in here. You can see the median nerve in here. The median nerve, one of the most used landmarks in endoscopic endonasal approach, and the median canal right here, it is identified at the base of the medial pterygoid process. So when we drill the middle pterygoid process from the anterior to posterior, and it access to inferior compartment of the foramen lacerum, also we need to find in our dissection or our surgeries. It is not required steps, but I want to mention because between the V2 and sphenoorbital fissure, there is a bony compartment and it's called maxillary strut. When we remove the maxillary strut, we can reach the quadrangular space right here, and we can also reach the Meckel's cave from there, and middle fossa dura a little bit. So it is important if we go for also the middle fossa approaches, we can use drill out the maxillary strut and we can reach this region. So in this photo, you can see I drilled a little bit of around the Vidian canal, so exposed the Vidian canal. Also between the V2 and V3, I'm going to show in further. There is also bony, some bones in there, and it calls mandibular strut. And after we remove the mandibular strut, also we can reach the below part of the middle fossa and the V3 region. And in this type of approach, you can transect the Vidian nerve or you can preserve the Vidian nerve. It depends of the surgeon's choice and the case. But if it is not required to transect the Vidian nerve all the time, you can also reach the foramen lacerum place without to transect the Vidian nerve. So as you see, I removed the mandibular strut in here. And also opened the foramen ovale. You can see the V3, the mandibular nerve is just going along in the canal, and the V3, it is the V2, and it is between this space, it is the middle fossa dura. For the cadaveric purposes, I cut the Vidian nerve to expose in a better way. But I'm gonna also want to mention about, you can see the Vidian nerve is the continuation of the median nerve. It just joins the fibrous tissue of the pituitary fissure in here. So it just runs lateral to the foramen lacerum at the middle of the middle cranial fossa is the lacerum foramen, and it is the median nerve just joins this fibrous tissue in here. It is the close-up picture. I like to take this type of picture so I can realize that where I am, which steps I am in here. You see, we performed the pterygopolitan fossa approach and we are done with it. So we can proceed our second step is the far medial inferior transclavial approach. So after complete the transpterygoid approach, we're gonna start the drill the clivus and the sphenoid floor, and we increase our exposure in this region. We're gonna keep going to drilling, and also we remove the nasopharyngeal mucosa and we expose it and we start to resect the mucosa. We can go down like until we find the C1. You see I remove the mucosa and the basopharyngeal fascia, and this muscle that you can see is the longus capitis muscle, and just medial of it you can see the anterior atlanto-occipital membrane. In the further dissections, I reached the C1. It is the posterior arc of the C1. It is the foramen magnum level, and it is the membrane, and it is the muscle. You can see. So the third step is the extreme medial endoscopic endonasal approach, and they can refer the sublacerum approach. But when I studied the jugular foramen region, I get a little bit confused because the extreme medial, the meaning is the midline, because the most extreme medial, you can reach the midline. But maybe you also confused about why they call it the extreme medial endoscopic endonasal approach, because for the region that craniovertebral junction or the jugular foramen region, we mostly use the extreme lateral approach. So for the refer this approach, because they called it extreme lateral approach, they called the endoscopic endonasal approach as the extreme medial approach. But I say terminologically it can cause you it can give a like confusion about this. So I think the sublacerum is more suitable to define this approach, but you can use both of them. The literature also use both of the names of these approaches. So after I remove all the fascia and the mucosa, you can see the longus capitis muscle is a better fascia. I'm going to put some illustrations of to orient you to the anatomy. It is the longus capitis muscle. We are looking from the anterior to posterior in the coronal plane. In this step, it is the important thing that we need to dissect the Eustachian tube from the middle pterygoid plate, because for reaching the jugular foramen region, we transect or we mobilize the Eustachian tube. So for both of them, we need to first dissect it. It is the Eustachian tube is coming from the nasopharyngeal segment to the foramen lacerum. And after I dissect everything, you can see the longus capitis muscle in better way. After taking the longus capitis muscle, there is another muscle just below it. It is the rectus capitis anterior muscle. The attachment of this muscle is important, and I'm going to mention about it in further dissections. And the new muscle is the rectus capitis anterior muscle. You see, after cutting the longus capitis muscle, it just seen and the rectus capitis anterior muscle. So mobilization or resection Eustachian tube. Like I said, first we need to dissect the Eustachian tube from the medial pterygoid plate, and then we just clarify and put all the segments of the Eustachian tube. It is from a mobilization study. It is they divide the segments of the Eustachian tube. If we need to perform mobilization or resection of the Eustachian tube, we need to cut from the foramen lacerum segment of the Eustachian tube. After we cut in the foramen lacerum segment, we can retract to the inferior laterally, or if we need to remove all the Eustachian tube, also we have additional cut from the nasopharyngeal segment, and we can just remove the Eustachian tube. But it can also cause some problems. It is not that innocent or simple procedure. After we even dissect and retract the Eustachian tube or the resect of the Eustachian tube, it can cause the transient palatal numbness, conjunctive hearing loss, middle ear effusion. Even sometimes it required another surgery. We need to insert the pressure equalizer tube insertion to the middle ear so we can pressure the pressure in the ear. So as you can see, I cut because of it is the cadaveric study. I not trying to retract the Eustachian tube. I cut from the nasopharyngeal segment and the foramen lacerum segment to the Eustachian tube. So it reveals also the another muscle. It calls rectus capitis lateralis muscle, and you can see the atlanto-occipital joint. It is the membrane of it, and some bony structures. And like I mentioned previous of my talk, we need to identify some of the bone structures for the keep going to the procedure. So you can see also the fibrous tissue that the median nerve is joins in the pterygosphenopelvic fissure. And after I remove the rectus capitis anterior, you can see the attachment of the muscle. And it mostly attached to the supracondylar groove. The supracondylar groove is important because it mostly estimates the position of the hypoglossal canal. So in the hypoglossal canal, we know of the hypoglossal nerve going for the hypoglossal canal. So it is important to understand the understand and define the supracondylar groove. For expose this region, we need to make the partial removal of the atlanto-occipital joint and the capsule of this joint. So as you see, I remove the fibrous tissue in here, and after I remove the fibrous tissue, it just revealed that this is the foramen lacerum segment of the internal carotid artery, and this is the sublacerum region. So I need to go there and find the jugular foramen. So it is important to identify the occipital condyle and the jugular tubercle in this type of approach. It is from the Juan Fernandez Miranda's paper. As you can see, it is the jugular tubercle and it is the occipital condyle. Between the jugular tubercle and the occipital condyle, you can see the supracondylar groove. And it mostly estimates it is the hypoglossal canal, and the hypoglossal nerve you can see is just go enter to the hypoglossal canal. So if we can define these bony structures, we can estimate, okay, it is the hypocondylar canal and the hypoglossal nerve is hypoglossal canal and the hypoglossal nerve is going from there. So we can careful for the lower cranial nerve injury. Also, in the inferior far medial transclavial approach, we can go just laterally and expose the inferior petrosal sinus. In this cadaver, it is not looking so good, but you can maybe select this bluish thing. It is the inferior petrosal sinus in here. It is just running along the petroclival fissure and joins the jugular foramen region in here. So after I opened the below of this region, there is a lot of venous plexus in here, so it is important. You need to care about all the bleeding and the cranial nerves. You can see it was the supracondylar groove, and I drilled a little bit more and I exposed it is the hypoglossal nerve, as you can see. Just upper side of the hypoglossal nerve, we're gonna find other lower cranial nerves. So I further my dissection to the upper side. You see, it is also from the Juan Fernandez Miranda's paper. It is a really nice illustration. You can see the hypoglossal nerve, which I am trying to show in this cadaveric dissection. And also there is a lot of some venous plexus in here. Just upper side of it, you can see the lower cranial nerves like vagal nerve, glossopharyngeal nerve, and accessory nerve. And also, again, I couldn't show it very well, but there's a bluish thing in here. It is the internal jugular vein. It is going behind of the carotid artery and goes just lateral of the carotid artery. And also the cranial nerves in here. And it is the pharyngeal segment of like C1 segment of the internal carotid artery in here. So this type of approach, we need to understand the internal carotid artery anatomy. We mostly use the body classification, and I'm going to show in here. You can see it is the C1 section, is the cervical section, and it just goes the petrous bone until the posterior edge, the foramen lacerum. It is the petrous part and lacerum part. It's coming from the cavernous part until the proximal dural ring, and between the distal dural ring and the proximal dural ring, it is the colonoidal segment of the internal carotid artery. So it is the last picture. It is the picture that we performed the procedure. You can see it is the cella, it is the paracellular region, and we are in here. We are in the jugular foramen region. Like I said, for the reaching and understanding the neuroanatomy, we need to expose the median nerve, also the pterygopalatine place region, so we can go the below part of this region and understand the sublacerium anatomy. It is sometimes hard to understand the depth of the structures and understanding the anatomy in the 3D way. So in this lab, we are performing some 3D models. I'm trying to show. Sorry. Yeah. As you can see, the depth between the structures is much different from the two-dimensional photos. You can see the ICA along from here and the Jugular Foramen region, pterygopalatine approach. Also, we had other approach 3D models in our lab website. It is the Almeida skull-based SketchUp account. You can reach the others models and you can work on the others model on it, and you can study it. You can try to understand the anatomy in the three-dimensional way. Like I said, I think it's the jugular foramen region from the endoscopic endonasal route. It is one of the hard concepts that learn for a neurosurgeon. Most of this type of surgeries also in Indianapolis, Indiana University, they work as a team with the ENT colleagues. So I also raised in that way with Dr. Şahin and Dr. Çeltikçi. So especially for the resection or the mobilization of the Öztekin tube, I strongly suggest that you should work with an ENT colleague. I thank everybody who joins this meeting. I think for essential part performing this type of surgery, it starts with the work and understand the anatomy of the approach in the lab first. And for the endoscopic endonasal approaches, if you start new, I think this type of approach shouldn't be your first cases. We need to first improve our endoscopic endonasal skills with the midline skull-based surgeries like the cellular or paracellular region. And then after we understand the anatomy perfectly and improve our endoscopic skills, we can try to perform this type of surgeries. So I need to mention this guy, Almeida, Dr. Almeida. He is my mentor in here. He always pushed me for this type of approach. I never performed pterygopalatine fossa approach or this type of jugular foramen approach before. And when he proposed me the first, you need to do this approach. I was disagreed because I think it is the ENT's job. I don't want to go there and learn this type of things, but he always encouraged me and you need to understand the anatomy because if you want to be skull-based surgeon, it is not just doing this type of surgeries. You need to expand your point of view. So I am really thankful for him and all the things that he did for me. It is my message, it is my motto since my second year of my neurosurgery residency. I saw in one of the presentations of the Ali Krisht, and I think it is also perfectly fit for the endoscopic endonasal approach. We should know our limits for this type of surgeries, but we need to work, we need to improve ourselves, and we don't have any limits. You can reach me for any further questions, not just relatively this topic about the lab, about everything. It is my mail address and it is my social media accounts. You can reach me directly, contact me about any questions. Thank you so much again for inviting me and let me do this conversation and this presentation.
Thank you very much, Dr. Erol, for this great presentation. And even as a medical student, I learned a lot from this. Before moving on with the discussions part, we have some distinguished faculty members and colleagues joining us today. So if they are available, I'd like to ask them if they would like to have any contributions. Professor Dr. Erdal Coşkun, if you're here and if you're available to talk. Or Professor Bülent Düz and Professor Dr. Abuzer Güngör. Any of you are more than welcome to have any contributions. And if you could unmute them.
Hi, everybody. Thank you, Gökberk, for your distinguished presentation. And I want to thank the Professor Kamil Sucu to organize this kind of meetings. And you showed very beautiful pictures and the very educational presentation you presented. I think we will see in next year your beautiful cases about I know this because I did the same steps before the operations. Any young neurosurgeons get these steps, and in next years we will see your beautiful cases with this information, with this anatomic information. I know this. Thanks again for your beautiful presentation.
Thank you, sir.
Thank you for your comments, Professor Güngör. And Professor Coşkun, I have sent a request for you to turn on your microphone. Yes, perfect.
Thank you for your excellent presentation. We emotional, deep afraid during watch this presentation because he entered small picture and go. It was perfect. Thank you.
Thank you, Professor. Thanks for your kind words.
Thank you for your comment, Professor Coşkun. And Professor Bülent Düz, if you are here, maybe we can take some comments from you. Okay. Wait a minute. He is entering from another device, I think. Professor Düz, I have sent a request again. And if you turn on your camera, you can come. Okay.
I didn't hear you, so because I was trying to establish my settings. Did you let me to talk?
Yeah. If you have any comments or something to ask, we will be happy to hear from you.
I have listened his contributions very excited with that speech. His anatomical study is very important to access jugular foramen and from every approach. But for the next level, I wish to hear from him for which kind of pathologies that we can use that approach, and how can we deal with the venous structures with that area, because this area is very hidden. We do not want to hear limits, but with that area, you know that the venous anatomy is very challenging in that area. With this approach, I think we need some help from endovascular team, and I think that we need some help from ENT surgeons. So this is a very challenging area, and his work is very valuable. Thank you very much.
Thank you, Professor Düz.
I'm gonna answer the Tarık's question, and at the same time, I couldn't show any illustrative case or the video images, but I watched a couple of cases from my mentor in here, JP, and most of for the endoscopic endonasal approach, all the literature, also my professor, and also I dissect in the cadaveric lab, and I suggest that if we are dealing the tumors originating from the midline and the extradural and spread laterally to the jugular foramen region, like clival chordomas or chondrosarcomas, endoscopic endonasal approach, it is suitable for this type of tumors. But if you are dealing for like glomus jugulare tumors, like most common tumors of the jugular foramen region, or some schwannomas, maybe meningiomas, endoscopic endonasal approach, I think it is not suitable for the primary jugular foramen tumors. And if you go for the primary tumors, like the jugular, like glomus tumors, I think the inferior temporal fossa approach or some far lateral or lateral approach is more suitable, and we are more familiar than this. In the cases that I watch from the Dr. Almeida's, there is a lot of venous bleeding. Like you open also when you open the cavernous sinus like this, there is a lot of venous bleeding in this region too. But they was successful stop this bleeding with hemostatic agents like Sogifilo, like some pressure with the pedis. They mostly stop the bleeding, but I strongly, totally agree with that. Even for the endoscopic endonasal approach, I think we had to be a team with the ENT surgeons because they obviously know this anatomy much more better than us.
Okay, maybe we can take the word of the next lecture from Dr. Erol based on the surgical cases.
Yeah, I can talk with my
Agent.
professor in here, and I can arrange this type of thing.
Yeah, we will be glad. Okay, thank you. And Muhterem, I think Dr. Erol already answered the question in the chat part.
Yep.
But you can also read it.
Okay.
Anyway.
So the question was, first of all, thank you very much for excellent presentation. Is there any intraoperative live video images to discuss this section?
Like I said, I watched some of the cases, but I don't have my case, of course. I am like 2-year neurosurgeon. Yeah. Like Dr. Güngör says, hopefully in the future, I'm going to perform this type of cases. But like Professor Sucu says, I'm trying to arrange, maybe showing this type of case. Maybe the Dr. Almeida himself maybe give a speech about this.
Yeah. Maybe from Dr. Almeida, maybe both of you, maybe you can present his cases, and in this anyway, it will be good for us. Thank you.
Yeah, definitely. I'm gonna talk him really soon.
Looking forward to that.
Is there any other?
There are no more questions in the chat, as I see for now.
Yep. There is applause from Pınar Yıldırım Terazi.
Yeah. If there's no more questions, I think I could just ask one personal question myself. It is not that much related to the presentation, but we have many medical students joining us today, and I'm one of them. And honestly speaking, you have achieved a remarkable level of success early in your career. And basically, for those of us who are interested in pursuing our career in neurosurgery, what advice would you give regarding the importance of pursuing international research fellowships during med school or after med school, like during the residency and so on?
First of all, I am right now admiring all the medical students who are interested in neurosurgery, because I remember myself when I in 4th grade or the 5th grade, I was never do such a things that you're trying to do. Nowadays, you are chasing us like for the joining some papers, they are going for the some international fellowships for about neurosurgery, everything. I'm really admiring. I wasn't like this before, but you are much better generation. You are aware of something that you need to do. It's perfect. I talk a lot of medical students, and they can reach whenever they want to reach me. It depends on your career plans. If you want to move your plans in the future in the abroad, like in the international countries, like the United States, maybe Europe, I think you need to start the study of the steps the exam steps of this type of, like for the United States, you start to study about the USMLE steps maybe, because it's really hard competition about the neurosurgery. If you want to be a neurosurgeon or the neurosurgery resident, the competition is really high level, because most of the successful students, med students in United States, actually trying to be a neurosurgeon because of the salary gap. You need to going hard, but you are visiting a lot of clinics and you are learning from them. I think you should keep going for this, and you should try to learn for all the information. Some of you guys trying to learn from our textbooks, some Greenberg manual handbook, something. I never recommend this type of thing. Just trying to improve your English skills, like in a perfect way, trying to learn some, I don't know, statistics, SPSS, maybe some illustration, try to improve your skills in a different way. Know how to prepare some projects. What is the TÜBİTAK projects, everything like the BAP projects, maybe trying to join this type of projects, and just leave it at the flow. You are doing really good job. I think you need to keep going that way and just don't quit. And there is some challenges in this route. Every neurosurgeon has a lot of challenges in this room, but in time, if you consistently keep going to work, I think you're gonna pass every steps of your career.
So the key message is consistency is everything.
Yeah.
That's first. Okay, thank you very much. I believe there are no more
Relating
questions.
to Gasimova's question, Dr. Erol, you are talking about the publication count with Selim Bozda to be a neurosurgery resident in.
Yes.
Can you repeat this count?
Sure. Like 5 years or 6 years ago, I think as an IMG, not educated in the United States, it is much more easier to be a resident or attending in the United States. But if you want to be a resident in the United States, even you pass all the USMLE steps, they look for your publications also, the quality of your publications, the number of your publications, especially for the graduated residents like me, like Celine. If you want to be a neurosurgeon in the United States, if you want to do that type of thing, we need to really high quality impact research papers and the number of it. Like there is some Brazilian residents or Indian residents working in here right now, and they accepted from Indian University, but their CV, their number of the publications and the quality is really high, like above 40 each for even the PGI-1. So you need to be involved in projects, and you need to be active as academic way. It is not just enough how many surgeries that you performed as a neurosurgeon. They don't look like, if I came to United States and I want to be a neurosurgeon in here, and like I said, I performed 1,000 endoscopic cases or 2,000 endoscopic cases. It doesn't matter for them. What did I publish? What did I did? Of course, but also they care about my publications, my academic way. So you need to improve your academic skills, how to write a review, how to write original article, how to attend some projects. So I always tell every medical students, if you need any help about this relatively, you can contact me in every way. And we got some papers. Also, I know the Selim Bozda and the professor suggest some papers. One of the medical students also join this type of papers. It is important for young residents, also the medical students too, because when you're going to be familiar with that type of things in your residency, you're going to work hard. There's a lot of shifts, there's a lot of responsibilities, so it's hard to keep your time for the academic purposes. So if you learn how to write in your medical school, it is much more easier than the learning in the residency program. Of course, it is also including for your English. It is hard to spare time for learning English, learning the academic things, because you got like 10 on-calls, I don't know, a lot of patients, the surgeries. You need to learn also about your job, your improving your neurosurgical skills. So your time is the perfect time to learn this type of things.
as I understood, you need at least 40 publications, and 50 is better, you say. Okay, it's very high level.
I give my message.
It's the highest branch in the US, as far as I know.
Yeah.
Yeah.
Yeah.
Because we are trying to be a neurosurgeons. Like if you're going to be another specialty, it is not that much. The numbers not that much high, but for neurosurgery, it is huge. At least like they say, at least 45, 50, like 35, 40. I don't know. I even like have not that much publication. I'm trying to publish it, but it takes time and it takes really hard work on hard on that. But thankfully, we got some really good mentors like Professor Suju, Professor Güngör. They like encourage me, allow me to grow in the academic way. So I'm trying to my best, and I suggest you keep going. You're doing the best.
Thank you.
Thank you so much.
Thank you. Thank you, sir.
Okay, so we have finished all the questions and comments.
Yeah, we are done with the
it is time to finish this session. And I want to thank Erol for this wonderful lecture. And then I want to thank everyone who joined us tonight. Okay, hope to see you
Thank you again.
again. Bye-bye.